Greetings. This presentation is on disorders of conduction, meaning the electrical conduction of the heart. The two main categories in this presentation are disturbances of ventricular conductions and pre-excitation syndrome. Remember from cardiac A&P, the four properties of the cardiac conduction system are automaticity, excitability, conductivity, and contractility. Remember, we're talking about the electrical wave here. So each little cell, just like these people in this picture, have the ability to start the wave. This little guy in the middle says, "Hey, I want to start the wave." He gets excited. He conducts that excitement to the folks next to him, and they contract their muscles and send that wave down the line. This electrical pathway, the normal electrical pathway of the heart, goes from the SA node through the intranodal pathways to the AV node. Then the bundle of His, both bundle branches, and then the Purkinje system. That's important when we're talking about electrical conduction in the heart, that you understand that that normal electrical conduction pathway is a superhighway, and it sends electrical signals very fast through the heart. Here's a term for you to be familiar with: aberrant conduction. That's a single supraventricular impulse, meaning it comes above the ventricles, so that QRS is narrow, conducted through the ventricles in a delayed manner. That conduction, that electrical conduction, doesn't follow this normal pathway. It doesn't go through that superhighway of the SA, AV, bundle of His, bundle branches, Purkinje system. It goes through different tissue of the heart. Like I said, each cell has the ability to conduct the wave through that automaticity, excitability, conductivity, and contractility, and you get a sideways conduction. These are normally seen with bundle branches and some other signals, some other type of issues that we're going to talk about in this presentation. But yes, it can go through one bundle branch to the Purkinje system and then shoot through that intraventricular septum to depolarize the other ventricle in that sideways conduction. Alright, we're going to do a short introduction with bundle branch blocks, and we'll cover more in the 12-lead lecture. All supraventricular beats are conducted through the ventricles in a delayed manner because one bundle branch or the other is blocked. If that bundle branch, let's say in this example, the right side is blocked, then the signal will move down that left bundle branch into the Purkinje system, and then the electrical signal will go through the intraventricular septum and depolarize the right side of the heart. This takes time to get through that septum because it's not using that super highway called your electrical system. So if the right bundle branch is blocked, it's a right bundle branch block. If the left side is blocked, it's a left bundle branch block. If both bundle branches are blocked, then it's a third degree or complete heart block. And you can read the various causes on the bottom of the page. All right, with bundle branch blocks, the QRS complex is normally wide, which is greater than 3 little boxes, or 0.12, because of that slower conduction going from side to side. The QRS complex looks bizarre. It can be called notched or slurred, or R and R primed, or have rabbit ears. If you look, here's a good example of a rabbit ears there. So in the right bundle branch block in V1, a R prime is more noticeable in that. And that R primed, as in this example, comes from that delay. You get this signal going down the left side and coming back across to depolarize the right side. And that gives you that little delay and gives you that R primed signal of ventricular depolarization. Here are some examples of some right and left bundle branch blocks. With this one in V1, you have your R and then your R primed in V1. In your V6, you've got your R and then you've got your R primed there. You've got typical rabbit ears right there, R primed in V6 with your left bundle branch. Some people have you remember William Marrow. With your left bundle branch blocks, you've got a W in V1 because you got the R and the R primed. And in V6, you've got the M, R and R primed with the left bundle branch block. With the right bundle branch block in V1, you have an M in V1 and a W in V6. So, or you can, your book talks about the turn point signal, or the turn signal method. And that's just finding your J point, which is the end of your QRS complex, and the start of your ST segment, and you go backwards from there. So, say that's our J point there, right there. I'm not very good with the drawing thing. If you go towards the QRS complex from your J point, and the signal, electrical signal, goes downward in V1, then it's a left bundle branch block. Like you turn your turn signals down to turn left, and it works for right bundle branch blocks. You find your J point. I'm not doing very good drawing today. You find your J point. If your electrical signal goes up in V1, then you're turning your turn signal up to go to the right, and that's a right bundle branch block. It'll take a little bit of practice, but you'll get it. All right, what's the difference between SVT and VTach? Supraventricular tachycardia and ventricular tachycardia. Most of you say, QRS width. That's one way, because SVT has a narrow, less than 0.12 or 3 little boxes, and VTach is greater than 0.12 or 3 little boxes. But when you have SVT with aberrance, that can make that QRS complex a little wider and confuse you. So, there's a couple diagnostic things. Adenosine won't convert a VTach, and vagal maneuvers won't change VTachs. So that's a couple ways to remember that if you try those therapies and they're not effective, it's probably ventricular tachycardia. So there's a thing also called a fusion beat. The complex results when ectopic ventricular beats coincide with normal conduction. So, and that makes a long QRS complex, greater than 0.12, but just a little greater. So you've got to get those calibers out and count those little boxes. This fusion beat is normally the cause. Go ahead and take a little break from this presentation, copy and paste this URL, and listen to some fusion beat boxing. Next is Wolff-Parkinson-White syndrome. It's a conduction disorder where this signal goes through its own little pathway. Remember, the Wolff runs its own path. There's an accessory pathway between the atriums and the ventricles that bypass the AV node. So there's no slowing down at the AV node, and rates can get extremely high. So early in the conduction of the ventricles, and this is called the pre-excitation syndrome. The pathway's name, as you can see over here, is the bundle of Kent. The accessory pathway in Wolff-Parkinson-White is called the bundle of Kent. Wow, that sounds like a quiz question. Here are some WPW facts. The bundle of Kent is the most common bypass tract of the heart. WPW affects only about 2% of the general population, and about 70% of them have no evidence of heart disease. 60 to 70% of all Wolff-Parkinson-White are men. So, and most commonly it's recognized, you don't have symptoms of it until you go to the OR, silly man, the emergency room for a funny sensation, and they put you on an EKG and find this wave. If the conduction bypasses the AV node, how does the rhythm look? Remember that AV node is used to slow down the electrical impulse to allow that atrial kick to help fill up the heart, but it's being bypassed so that PR interval is shorter. The PR interval is less than 0.12 or 3 little boxes, and it has this little upstroke. In it called a delta wave. You're on your isoelectric line right here. You got a short PR interval and a delta wave, a little slur upward in your QRS complex. Isoelectric line and a little slur and a short PR interval. WPW, Wolff-Parkinson-White syndrome. You can remember this by WPW, wide QRS, PR interval is short wave. Wide QRS, PR interval short wave. And remember that the Wolff runs its own path, and that pathway moves it through the bundle of Kent. The bundle of Kent, because it bypasses that AV node. WPW, wide QRS, PR interval short wave. Recognizing this on EKG, remember, you got a wide QRS, the PR interval is short. You've got that upward slope of a delta wave. If they have EKG changes, they are at highest of risk of sudden cardiac arrest. It's a very fast rate. SVTs, AFib, flutter patients may have much faster rates than normal. Remember, look for that delta wave, that shortened PR interval, fast and irregular rhythms. That isn't torsades. It isn't torsades, so it's monomorphic. Recognize WPW on EKG. Since we are fast and we are wide, we need to slow things down. However, avoid calcium channel blockers, beta blockers, and adenosine, because we don't want to block any signals. Amiodarone is still acceptable. Procainamide is better. Remember those negative dromotropic effects of procainamide. And then they can do an ablation of the accessory pathway. Go ahead and access the links or copy and paste these videos into another browser, and then come on back when you're done and we'll finish. Enjoy. I hope you like those WPW videos. Now let's talk about some electrolyte abnormalities. Mainly the issues are with potassium and calcium. So let's review the electrolytes and the major roles in the heart. So sodium, remember, plays a major role in cellular depolarization. In the resting state, more sodium is on the outside of the cell, So then calcium helps sodium with myocardial depolarization, and calcium also helps with muscle contractions. So strong muscles, you drink your milk, right? Like your mama told you. Then potassium, K+, in the resting state starts inside the cell. It has to do with repolarization. You're eating those bananas to repolarize your muscles. Clyde, the chloride guy, helps with cellular permeability and moving sodium and potassium in and out of the cells. And then mother magnesium stabilizes the cellular environment. All important electrolytes. All right, potassium. Lab values for potassium are 3.5 to 5.0. In a hypokalemic state, you'll have flattened T waves or a predominant U wave. Look at this little U right here. So predominant U wave, which is inside that T altogether. And if you notice, this T as a whole is a little longer than normal. So we got a prolonged T wave. So in hyperkalemia, we have a whole bunch of potassium in there. So your heart can repolarize. Kabam! All of a sudden, really fast. That T wave is tall and spiked. It goes kabam! And it's repolarized, ready for action. So tall T waves, you can suspect the patient has a history of renal failure because they can't flush out this potassium in their urine. Levels approaching 8.0, the T waves will merge with your QRS complex. Look at this crazy wave right here. Things are getting ugly. Levels greater than 10 are incompatible with life. And here are lab values with T waves on EKG. Remember that our normals are 3.5 to 5. Our normals are 3.5 to 5. So in hypokalemia, 2.8, we got some delays. We definitely have a U wave in here. Prolonged repolarization. We've got a U and a prolonged. And then look at this crazy thing. That's not happy with that hypokalemia. And then with hyper, like we said, we got tall spiked T waves because that potassium goes kabam, and you repolarize quickly here. And then as it gets bigger, you have some crazy ventricular looking waves in the EKG from hyperkalemia. Next is hypocalcemia. Hypocalcemia could be caused by the use of diuretics and you're peeing out too much calcium or some certain endocrine conditions. Hypocalcemia prolongs repolarization and ST segment. So your ST segment's getting longer here. Your S to your C is a lot longer than normal with hypocalcemia. hypercalcemia, your repolarization time gets shorter. Your ventricles are contracting, bam, and then repolarizing right off the bat because you have some hypercalcemia, shortened repolarization time. Go ahead and click on the link or copy and paste this URL to see some hypercalcium channel girls and the Spice Girls from way back in the day. Most of you students probably don't even know what who they are, but it's amusing. So take a break from the presentation and have a listen to some hypercalcium channel girls. All right, Digitalis has a very narrow therapeutic range. So if your patients sort of forget to take it and they take 2, it can cause various changes on EKG. Remember that Digitalis is used in CHF for that positive inotropic squeeze of your heart. I know, squeeze my heart. Yeah, I know, squeeze my heart. And it's used for AFib because it slows that ventricular rate. If the heart's squeezing better, the rate goes down. So the effects on EKG is a sagging or a scooping of the ST segment. And you can notice that here. Big old sag in that ST segment. And a prolonged PR interval. We are about 6 boxes, which is 0.24. So sagging of the ST in a prolonged PR interval is a sign of Digitalis abnormalities. When you have a hypothermic patient, you can get what they call an Osborn wave or a J wave. It's a little upside down J, but you can see it on this QRS complex, a little upside down J. So it has and can cause that T wave inversion. Can be seen in sinus brady, AFib or flutter, AV blocks, PVCs, asystole, and VFib. So when you are cold, colder than iced tea, you may have a J wave. Another name for this J wave is the Osborn wave, and you can see this upside down J on this EKG. And well, everybody loves Ozzy Osbourne, and well, if you're too young to remember who he is, do some YouTube research and learn who Ozzy Osbourne is. The J wave. And we are here with everybody's favorite slide in summary. Wow, this is the last presentation where you learned new waves in your EKGs for cardiology. It's pretty crazy. We've talked about some calm waves, some normal calm waves. We've talked about some blocks. We've talked about some lethal and dangerous waves. Big waves and small waves. But we're done talking about waves with cardiology until we get to our 12 lead presentation. Go ahead and pause this presentation. Click on the link or copy and paste the YouTube URL into another browser and enjoy some waves. Have a good day. I hope you enjoyed the cardiology series.